Okay, I'm Simon Freeman. I'm an ENT and skull base and cochlear implant consultant at Manchester Royal Infirmary and Salford Royal Hospitals.
And I'm jointly presenting with Simon this morning. My name's Deborah Mawman. I coordinate the adult cochlear implant team here in Manchester. I'm an audiologist.
And just in case anybody's joined since my talk, I'm Simon Lloyd. I'm another ENT surgeon in Manchester. All the male ENT surgeons in Manchester, at least in the otology section, are called Simon, so it's quite easy.
Okay, so I'm going to start off. So we're going to cover cochlear implantation in a little bit more detail now. So first of all, just to go through some of the basics really. So we know that a cochlear implant is an electronic device that's used to treat patients with severe to profound sensory neural hearing loss. It consists of two parts, and what you can see on the screen at the moment is the internal part of the cochlear implant system. This is the part that's surgically implanted. It consists of a receiver stimulator package with a magnet in the middle. Simon, I'm not sure if you can kind of point these things out as I'm talking through. That's great.
Can you see my pointer?
I can see your pointer. Perfect,
right.
Thank you. So this is the
little
magnet in the middle. Yeah. So this is the part of the implant system that just fits underneath the skin at the back of the ear. This is the part of the system that picks up radio signals from an outside external coil that I'll show in a moment. Signals are transmitted along a carrier wire to the electrode array on this device. This electrode array at the end of the implant device is the part which is inserted into the cochlea. On the electrode array itself, and I don't think it's terribly easy to see it on this diagram, but there are a number of little electrodes that are placed inside the cochlea. And it's these contacts which we can stimulate in different areas of the cochlea. The signals from the electrode activates the nerve of hearing. These messages go along the usual auditory pathway to the brain, and then these signals are interpreted by the brain as sounds. The next slide illustrates the number of different cochlear implant systems that we use in the UK. There are 4 main manufacturers of implant devices. In fact, they all essentially work in very similar ways, but they will vary a little bit in the number of electrodes on the devices and the different ways in which we stimulate the device. So the next slide shows the one of the external parts of the device. This is called the speech processor. And as you can see, this looks very similar to a hearing aid. It consists of a microphone. At the top there, you can see number 4 are the little microphones on top of the speech processor. The sound processor itself and the power supply, which is labelled as number 14 there on the device. Then the external transmitter coil has a little magnet in the centre, which allows it to attract magnetically to the internal implant device. So this speech processor is worn behind the ear a little bit like a hearing aid. So if we go on to the next slide, you can see a little bit more clearly now how this all fits together. So underneath the skin, you have the receiver stimulator package, but on the outside, the patient is wearing this speech processor attached to a magnetic cable coil. So what happens is that sound is picked up from the microphone on the speech processor. It picks up acoustic sound in the environment and then changes this sound into electrical signals. These are transmitted along the cable coil. This signal passes through the skin radio waves. The signals are transmitted to the electrode array, which stimulate the nerves of hearing, and then, as I mentioned, these signals are then passed along the auditory nerve to the brain, where they're interpreted as sound.
Thanks, Deborah. Simon, can you tell us a little bit about who should be considered for a cochlear implant?
Yeah, so this brings us on to the NICE criteria, who basically set the primary audiological criteria for implantation. And they set the initial criteria in 2009, and it was revised last year. And this slide gives an indication of the changes. So if we look at the pure tone criteria, you can see that it's changed from 95 decibels at 2 and 4K to 80 decibels. And that's basically the patient only needs to have two frequencies, two individual frequencies between those frequencies, meeting that criteria to be eligible. And then the second test we do is speech testing, and that used to rely on something called BKB sentences, and the patients used to have to be worse than 50% correct. And we've now moved to the AB words, which are Arthur Boothroyd monosyllabic words. And again, we've kept the 50% criteria, but the two tests are not the same. So roughly, we think that the AB word 50% threshold is equivalent to a BKB sentence of 70%. So as you can see in 2019, therefore, the criteria was significantly relaxed.
So, Deborah, can you tell us a little bit more about what AB words are, what the word lists are, and how the testing's done?
Yeah. So, as Simon mentioned, the AB word test is a monosyllabic word test. And we now use this test to determine candidacy for cochlear implantation in adults. So what you can see here illustrated is a patient sat in front of a loudspeaker. And we present the patient when they're sat with their hearing aids on with a series of single words, for example, dog, cat, house. They're examples of the monosyllabic words that we use. The speaker is calibrated, so we're always presenting speech signals at 70 dB, so it's the same for every patient that we test. We also use this test post-operatively to monitor performance with the cochlear implant. So each of these monosyllabic words have 3 phonemes in them. And you can see now on this slide examples of these words. So on the left-hand side, the first word that would be presented to the patient is the word fish. If the patient was able to repeat that word back correctly, they would score 3 points. The 3 phonemes are F, I, and sh. So if the patient were to repeat the word back as fin, then we would score 2 points for that word. So they've been able to correctly repeat back the initial consonant and the vowel sound, but incorrectly the final consonant sound. So then we go through a list of these individual words and then add up the phoneme score at the end of the list.
Brilliant, thank you. That's really clear. Simon, are you able to just tell us a bit more about how cochlear implants actually work?
Yes, so I'm going to just touch on the anatomy. So essentially, a cochlear implant is to replace the function of the cochlea itself, which is to transduce sound energy into electrical energy. And the cochlea does that by measuring the frequencies of the sound waves because of the specific characteristics of the basilar membrane, in that it changes width and stiffness as it goes along the cochlear duct. And what that means is that for postlingually deafened patients, the cochlea is tonotopic. So stimulation at the basal turn gives high frequency sound to the brain, and at the apical turn gives low frequency. Now, if you consider speech, and that tends to break down into fundamental frequencies, which are displayed in this graph. And what a cochlear implant is able to do is, because it only has a limited number of electrodes, we need to equate those fundamental frequencies to specific electrodes. And so by stimulating at specific points in the cochlear implant, we can mimic those fundamental frequencies in blocks, as is displayed in this graph. But the other really important thing is that the brain needs to be able to interpret those sounds. And that's fine in a postlingually deafened patient who's already learned that. But of course, we're not born with that ability. We have to learn it. And while this may be more relevant to pediatric cochlear implants, it still has relevance to adults as well. The brain has to receive sound very early on in order to lay down these neural pathways, while it's particularly plastic, which is in the very first 2 or 3 years of life. So ideally, we're trying to implant children as early as possible, and practically that means at about 12 months for various reasons. But it's also relevant when we think about the contralateral ear. So sound stimulates the contralateral auditory cortex primarily. It will give some stimulation to the ipsilateral cortex, but the auditory learning is limited. And that's relevant when we're dealing with sequential cochlear implants, where there may be a long gap between implanting one side to the other, or indeed in a congenitally deaf ear, where there's been hearing in the other side, and we're going to come back to it later on. So by the age of about 5, if there's been no hearing, children have basically lost the ability to hear sound. Whereas in the sequential implants, we probably have sort of 10 to 12 year gaps because of that unilateral stimulation.
Brilliant. Thank you very much, Simon. So we've talked about how they work, but Deborah, can you give us an idea of what kind of outcomes you can expect from an implant?
Yes. So I think it's fair to say, and I know Simon will expand on this in a little while, that there really is a lot of variability in terms of outcomes for implants in adult patients. And I think it's fair to say that we still don't have a very good way of being able to predict the outcome for any individual. But instead we can generalize about how patients do. And I think it's fair to say that in general, that our patients who have a relatively short duration of profound deafness and a history of good hearing aid use, then we might expect them to benefit more from an implant. These patients tend to report when we first switch their implants on that at the beginning speech sounds robotic. Some people describe it like a cartoon character or a Dalek-y sound. Sounds a little bit artificial at the beginning, but it is speech-like, and people are able to follow conversations when they're listening with their implant, even very early on. But with time, a lot of these patients will go on to develop very good listening skills and may even go on to have very easy two-way conversations with other people on the telephone. For children, we know it's possible for them to achieve age-appropriate, receptive and expressive language skills and develop very intelligible spoken language and can go on to, you know, mainstream education. However, for patients with a longer duration of deafness and more limited hearing aid use, then I think it's fair to say that we perhaps expect more limited benefit from the implant. And very often these patients at the beginning will report that they don't hear speech-like sound, that they can hear beeps and buzzers through the implant, but that with time the sounds do start to develop, and the patients can go on to hear sound around them in the environment and recognize different noises around them. And it will of course help with their lip reading. It's probably not something that will improve speech intelligibility in patients with a congenitally deaf onset of hearing and some a deaf intonation to their speech. Then an implant will probably not help to improve that speech intelligibility. And progress might be quite limited for some of these patients. So, yeah.
And have you got that graph, Deborah, we were looking at, you know, the BKB?
So,
oh yes, I'm going to come on to that.
Oh, okay, that's fine. That's good. Okay, so I mean, we know that there is a range. Oh yeah, that's the one. Fantastic. Sure, I mean, this
changed the order, Simon, just to confuse you.
Yeah, that's fine. Do you want to quickly go through that, because it's a lovely slide that it really shows nicely the range of.
Yeah, so this was to think about the variation between users, and this shows our outcomes as you can see over an 18-year period. They're 9-month cochlear implants outcomes. So by that point, patients should have completed the sort of learning effect and should have reached the good point, if you like. And you can see that the BKB score is here, and then the year of testing here. So for instance, in 2014 is that column. And you can see that most patients do really well and are getting high scores. As Deborah says, a lot of patients are getting up between 90 and 100% and are able to converse normally, particularly in quiet surroundings. Certainly because it's only one ear for adult patients, they may still find it difficult in noisy environments, and they may still find it difficult with music, because music requires the frequencies across the whole spectrum, whereas a cochlear implant gives that sort of blocky stimulation that I showed earlier. You can also see that over time, implants seem to have got better. I don't know whether that's partly our criteria have changed, and we were taking only very profoundly deaf people, but now we're including people with some residual hearing, and therefore they tend to do better. But you can also see that even now we're still getting a proportion of patients that don't do very well. They're probably doing better than they were pre-operatively, but in the outcome of BKB sentence testing, there is still some significant variation.
So there's obviously quite a bit of range there, isn't there? Are there certain things that you know will affect the outcome?
Yeah. So I mean, as Deborah touched on, clearly there are some patients where there is it's unknown, but in our MDT, where we take a number of factors into consideration, and this principally comes down to two pathways. What level of auditory input can we expect? In other words, what's the cochlear patency and how might the nerve be functioning? And what level of auditory processing can we expect? In other words, what do we think the patient's going to be able to do with the signal once it gets there?
Okay. And are there any particular conditions that can affect those things?
Yeah, so in thinking about auditory input, in order to assess cochlear patency and nerve patency, we have tests available to us. So everybody gets an MRI scan. That's good at looking at the fluid signal within the cochlea and looking at the nerve itself. Adults tend to get a CT scan because that gives us bony anatomy, and it can help us with surgical anatomy. It can help us diagnose otosclerosis and sometimes chronic otitis media issues. We occasionally get someone turning up and we find they've got a mastoid cavity, and so that can be helpful. And so, oops, sorry, jumped. So just thinking about some examples. So more relevant to pediatric implants is inner ear malformations. There's a wide spectrum of malformations. Clearly, a labyrinthine or cochlear aplasia will not be implantable, but for all the others, we can have a go at implanting, but there may well be limited outcomes. The more mild abnormalities, things like Mondini and wide vestibular aqueduct, we know the outcomes are actually very good. And then we've got the acquired issues. So iatrogenic, for example, we might have done a labyrinthectomy on a patient for Meniere's, and that could lead to labyrinthitis and loss of patency within the cochlea. The commonest reason we see for loss of patency is meningitis. And here we can see a scan just showing that should be a nice white signal through the basal term, but you can just see that there's only a couple of dots there. And here we've also got otosclerosis. So here we can see that the very narrowed basal turn with the typical halo sign that we see in advanced otosclerosis. And then inflammatory causes, particularly otitis media, which may be acute or chronic, cholesteatoma, can all lead to labyrinthitis and subsequent labyrinthitis ossificans. Trauma might be another one, temporal bone fractures.
So there's obviously some patients that aren't implantable.
Yeah, absolutely. So, you know, if we take the cochlear patency, for example, so if, you know, we know that some of those meningitis have a complete whiteout on their signal, and sometimes we'll try drilling out that basal turn, but we know if there's no anything visible on the scan, then they're unlikely to get a useful outcome. Moving on to the nerve causes, there's congenital nerve abnormalities. I'm just showing an array of abnormalities on the parasagittal sections here of complete eighth nerve aplasia, cochlear nerve aplasia, or a hyperplastic nerve. And this is an axial scan showing a very narrowed IAM. And then there are the acquired causes. So most commonly is a vestibular schwannoma, but other tumours within the IAM or CPA may well affect nerve function. As we know from our NF2 population, having a vestibular schwannoma doesn't necessarily mean that a cochlear implant won't work. And we have some very successful results with cochlear implantation in vestibular schwannomas that have been managed conservatively, or even with radiotherapy or Avastin. And then there are other rarer causes of nerve damage, temporal bone trauma, surgical trauma, inflammatory causes. And I've put degeneration there because we know that there can be some neuronal loss with things like presbyacusis, and there's certainly theories that that might reduce the outcome of cochlear implantation. And coming back to your issue with oh no, I'm jumping, sorry. Next question. I haven't touched on auditory processing, have I?
Yeah, no, yeah, I was just going to ask you. So, yeah, we've talked about the sort of problems with actually implanting the patients, but what about the patients that have got auditory processing problems?
Yeah, well, that's right. And unfortunately, I don't have nice, pretty pictures to show as to how we can assess this.
Actually, this might be a good point because it's not really adult stuff, but we were talking about auditory neuropathy earlier on. Somebody asked about that, and we could just briefly touch on auditory neuropathy and cochlear implantation as well in this area, if you can.
Yeah, absolutely. So, I mean, auditory neuropathy spectrum disorder is so called because it's a spectrum, and there are no doubt different causes that contribute to ANSD. Principally, we split those into what we term auditory desynchrony, where we think there is a problem with relay of the signal from the hair cells to the nerve. And that can actually be overcome quite well by cochlear implantation. So if the MR scan shows a normal nerve, our expectation is that a cochlear implant will work very well for auditory desynchrony, even though the hearing aid is providing limited outcome, and their thresholds may be okay. But because of the desynchrony hearing aid, they just hear a garbled message. But a cochlear implant usually is able to overcome that. But the second group is those children with cochlear nerve deficiency, where the MRI shows an abnormality of the nerve, and they might still present with that phenotype of ANSD with an absent ABR, but a present cochlear microphonic or otoacoustic emissions. But the reason they're not hearing is because the nerve itself is abnormal, and as we've shown earlier, they tend to do much more poorly with cochlear implants.
Okay. So, okay, go on. Sorry, Simon.
So just touching on auditory processing issues. I mean, I put a list up here. We've already talked about congenital deafness and the fact that the brain doesn't develop the ability to interpret sound. Now, of course, that's not black and white, because if someone's born with profound deafness but has a little bit of hearing and is given aiding, then they will develop an element of auditory processing. And this is where it's relevant to adult cochlear implants, because of course we're seeing more and more patients presenting to us with congenital deafness and wondering whether they can have a cochlear implant. And while somebody who has never heard and basically has no oral communication and communicates with sign will not be able to make sense of a cochlear implant signal, and we would not implant them. There are a number of patients that do have a little bit of use from hearing aids, do have a little bit of language, have developed a certain amount of speech, and are potential candidates. And the same goes for sequential cochlear implants, as I touched upon earlier. Really, the main issue is the duration of the gap between the first cochlear implant and the second. Yeah. And with regards to postlingual deafness, again, that long duration is a significant issue. It used to be that we would consider 20 years to start to be a factor. Now, with more recent studies, that's been less of a factor, and we're seeing patients that have been deaf for 40 or 50 years still get reasonable outcomes, but it's a lot more variable, and they certainly have to be cancelled accordingly. I've put poor engagement and practice in there because, as Deborah touched upon, a cochlear implant doesn't work as soon as you turn it on. There's some element of sound input, but the brain has to be trained to that. And patients that won't engage and practice with their cochlear implant just aren't able to use it effectively and may well become non-users. I've touched on cognitive disorders because, for the same reasons, if they're not able to engage because of severe cognitive issues, then they may not be able to interpret the signals. We know things like severe autism can mean that they aren't able to use their cochlear implant, and acquired issues such as a severe stroke and things like that can also mean that they can't use a cochlear implant. And then finally, I've mentioned inherent ability, because we know that there just seems to be variation that is unexplainable. And just like there are people out there with dyslexia who struggle to process the written word, we have no doubt that there are people out there that find it more difficult to interpret sound and speech. But we don't have a good way of being able to measure this and identify it preoperatively.
Yeah. So thanks, Simon. That's really clear. Just to say, if anybody's got any questions, just ask, and we can answer them through the chat. I wanted to move on now a little bit to assessment. We've already talked about audiological assessment a little bit, but it's not just about the audiological side. So Deborah, could you just talk us through a little bit about that?
Yeah, so all of the patients who are referred to our department for a cochlear implant are first assessed by the audiology team, and at that initial assessment then we would take a pretty detailed history of which includes the history of hearing loss, any comorbidities, use of hearing aids, any problems that the patient might have with their balance or tinnitus. We also look at the history of hearing aid use and discuss the social, work and home situation for the patients. And then at that initial candidacy assessment, that's when we will carry out the hearing test that we've talked about already, the pure tone audiogram and the AB word test. And then if at that stage the patient meets the audiological criteria for a cochlear implant, then we go on to do more assessments with the patient. Simon's talked about the MR and CT scans that we do with all of our patients. But in addition to that, it's really important that these patients are fully informed about cochlear implantation and develop realistic expectations about what benefits they might get from it. So we invite everybody to an information session. Most of our patients come to a group information session, but if that's not appropriate for the patient, for example, if they second language English or BSL users, then they will attend a one-to-one info session. All of our patients are discussed at the we have a monthly MDT meeting. So then we will go through the patient history and make decisions about the type of implant that we're recommending for the patient, the ear that we're going to implant, and discuss any other issues that might be relevant for that patient. Then following on from the MDT, the patient's invited to a consultant appointment in the clinic where they're listed for surgery. And I know that Simon's going to go into a little bit of detail about the surgery in a moment, but then following on from the surgery, we will, and I'll talk in more detail about this later on, but we would then switch the implant device on usually a month after surgery, and then that's really when the hard work starts for the patient.
Okay, so we've had a few questions actually. So
Yeah.
Reshma asked, and we probably will deal with it later on actually to some degree, but she's asked whether the implantation process damages the existing hearing. Simon, I don't know if you want to answer that one.
Oh yes, you're getting feedback. I'm not sure why. There is certainly a risk of cochlear trauma when inserting an electrode, as you can imagine. You know, we're dare I say shoving a big silastic thing into a very delicate structure. Electrodes have got better and better over the years, and the modern electrode, certainly for the last 5 to 10 years, has become much better at trying to preserve the natural hearing structures. It's very difficult to preserve hearing in the basal turn, i.e. the high frequencies. But the low frequencies, we have a reasonable chance of preserving, and hence, you know, we'll take patients with so-called ski slope losses, so they've still got well-preserved low-frequency hearing, but poor high-frequency hearing and reduced speech understanding. And roughly speaking, we tend to tell patients that we can preserve that hearing to a useful level in about 70% of cases. The reality is, of course, that once they have their implant turned on, the implant works so well that a lot of them aren't interested in combining that with a hearing aid. And it's actually relatively few patients that, even though, you know, we pat ourselves on the back and say what a wonderful job we've done of preserving their hearing surgically, they tend not to use it.
Yeah. And Darren has also asked, there's obviously a range of cochlear electrodes available. How do you choose which one?
So we've tended to stick with Cochlear and Model as our main two providers for various reasons. So 10 years ago, when we started doing hearing preservation, we used the Model Flex Soft, which was the first of the sort of hearing preservation electrodes. At that point, Cochlear still had the Contour electrode, which is quite a stiff, wide electrode, and it was very difficult to preserve hearing with. At that point, we trialed very short electrodes, which probably were a bit better at preserving hearing. But the trouble is that over time, people tended to lose their natural hearing anyway, and then you were stuck with a potentially worse outcome from a shorter electrode. And as you know, when we've looked at our hearing preservations with the Flex 28 and the Flex 24, i.e. that's the length of the electrode in millimeters, there wasn't a big difference between the two, and evidence suggested that the 28 gave a better cochlear implant result, so we tended to move away from the 24. But then Cochlear had the 522 or the 622 as it now is, and that's a very fine electrode. Studies have shown that the hearing preservation rates are probably slightly better with the 622 over the Flex 28. And so I don't know, what, for the last 2 years or so, we've tended to use the 622 as our go-to hearing preservation electrode if we felt that there was significant hearing to preserve that might benefit the patient, i.e. that they might end up using a hearing aid afterwards, not just because we're going to try and preserve a bit of hearing.
Okay, brilliant. And just a really quick word on our scanning protocols. So Anel's asked, do we do a CT for all adult patients? And also quickly, do we do any vestibular testing?
So in terms of scan, we used to do MR and CT on everyone. And then there was a study that came out showing that CT in young children had the potential to increase the rate of lifetime brain tumor risk. I think it was 1 in 20,000 to 1 in 10,000. And at that point, we decided that we would only do CTs on children if it was really clinically indicated. And actually, we found that very few of them need CTs. It's only an issue of surgical anatomy. But in adults, the risk is not the same. And therefore, we do MRI and CT on everybody. That's definitely helpful. It's surprising how many so-called idiopathic hearing losses end up being something like otosclerosis. And that does affect what we do for cochlear implantation, because otosclerosis has an increased risk of facial nerve stimulation because of the quality of the bone. We tend to then would go for a modiolar hugging array like the Contour. So it does change our outcome.
Okay, we'll leave the vestibular. I think we'll leave the vestibular one because we do sometimes do testing for the vestibular patients, but we'll move on.
The answer is not routinely.
Yeah. Okay, brilliant. Thank you. So Deborah, can I? Oh no, Simon, could you possibly go through some of the surgical aspects then?
Yes. So I've just got a few more slides here. So. A brief summary of cochlear implant surgery is consideration of what do we do with the soft tissues, what do we do for the bony dissection, and then placing the implant. And that fundamentally, the bone dissection is cortical mastoidectomy, posterior tympanotomy. It says cochleostomy here. I hadn't realised that. It's an old slide. It should say removal of the round window niche and exposure of the round window, which is what we do for most patients. here's just an image of the standard small post-oral incision with a narrow subperiosteal pocket that's designed specifically to fit the implant itself. And then here is a silastic template that we use to check the pocket is correct. And then we tend to mark where we're going to drill and drill the channel. We used to drill a well, but modern implants have a much flatter profile, so they don't need a well generally now. And then this is demonstrating, once we've done the cortical mastoidectomy and the posterior tympanotomy, so we can see the lateral semicircular canal here and the short process of incus here, and the facial nerve will be between the two, and it runs round roughly in the line of the incus. And so we want to thin the posterior canal wall so that we can drill slightly in front of the line of the incus, and as we drill inferiorly, we stay parallel to the posterior canal wall. And we work our way through essentially between the facial nerve and the chorda tympani, which we can't really see on this picture. And once we're through, then it's important to identify the stapes and work our way down from them, because they're the next niche that we see is the round window. You can't quite see it on here. So I'm now going to take my life in my hands technologically. I'm going to try stopping sharing there and starting sharing, where is it? Here. There we go. Has that worked?
Yeah.
Excellent. And I've, as you can see, I've got one of the world's experts in cochlear implantation has kindly lent me his video demonstrating just removal of the round window niche. So we've got the promontory here and just using the skeeter burr, here you go, you start to see the round window in the depths there. There we go. So I'm just going to pause it for a sec. Here we go. So the round window's there, and here you're just using a needle to make a little hole in the round window. Usually we use a little bit of dexamethasone around just to try and help with preservation of vestibular and cochlear structures. And here, this is the electrode is just being fed, the tip gets fed into the cochlea and slowly pushed forward until it's fully inserted. And then once it's fully inserted, a little bit of muscle or fascia gets placed around it to seal the round window and try and stop any further perilymph leak. So I will now go back to the talk.
Brilliant. So that will look pretty straightforward, but it doesn't always go quite to plan.
Well, it was expertly done, wasn't it? So,
well, I can always choose the easiest cases to put in the video.
That's certainly the ones to show other people. No, of course. And, you know, there are all sorts of reasons why it tends to be it can be quite difficult. You know, the nice thing about having the CT on adults is if you've got a sclerotic mastoid or a low jaw or an anterior sinus, you can be pre-warned. And certainly at the beginning of the case, I'll always go through the CT with the trainees and just, you know, so they're aware of what they may or may not find. And finally, this video is just showing with the implant in situ. You can see it's back in its pocket. The Cochlear device has a ground electrode that's separate. The other devices have a ground electrode that's on the receiver stimulator package. And then we just tuck the active electrode array into the mastoid. And then we sew up the periosteum. So we've got a nice tight periosteal pocket with some pressure holding the implant in place, and then close up. Post-operative management. So, you know, we used to keep people overnight, but about 10 years ago, we moved to day case surgery, and it's been very clear that that works very well. Head bandage only stays on for a couple of hours to try and prevent any hematoma formation. We use 2 or 3 doses of oral augmentin after just over a 24-hour period, and then they're followed up 1 week and come back for switch on with the audiologist at 3 to 4 weeks. At 1 week, we see them in clinic. We get Stenver's post-op x-ray. I'd love to be able to tell you the exact angle of that, but I'm never quite sure. It's something sort of coming in at 45 degrees, I think. But here you can see the lovely view of the electrode array doing that nice 360-degree turn within the cochlea, as well as seeing the rest of the package. And then just a slide on complications. So this is the sort of list that we will consent patients for. The main concern is a facial nerve palsy. Fortunately, that's very rare, and we tend to quote about 1 in 1,000, as I would for a mastoid operation. Vertigo and imbalance is unusual, but unfortunately it can occasionally be quite severe, and a bit like a severe episode of labyrinthitis can knock someone off their legs for a little bit of time. Most people will recover fairly well, but it can take a few months. And of course, there is the occasional patient that might not. And these deaf patients may well have some vestibular issues already. So you may well find that you're dealing with someone with a bilateral vestibular loss. So occasionally that can be quite problematic. As with any mastoid surgery, we talk about taste change and chordotympanoid damage. Patients can get worsening tinnitus, particularly after the surgery. Usually the implant actually is a good treatment for tinnitus. So once it's switched on, most people will find that improves with time. And then you have wound complications and infections and skin breakdown and device extrusion, all of which cause us some concern down the line. And occasionally, about 1% of the time, patients end up losing their device because of these things. Meningitis and CSF leaks are very rare. Every patient has to have a pneumococcal vaccination if they haven't already had it. The original cochlear implant studies suggested a meningitis risk of about 1 in 5,000, but things have moved on so far now that I suspect the risk is even less than that, particularly with the vaccination. I can't recall ever seeing it in a post-op patient just because, without another obvious reason. And then finally, unfortunately, we do our best to hold the device down and get it in the right place and hold the electrode down, but occasionally these things move, and that's why we do the post-op x-ray, and occasionally we have to go back in and either move it back or replace it.
Brilliant. Thank you, Simon. So I think the final few words were going to be from Deborah about rehab and that kind of thing. Do you want to just tell us a bit about how you go about giving rehab?
Sure. Yeah. So perhaps just briefly to go over the switch on, which we've already talked about, that occurs usually about 3 to 4 weeks after the surgery, and that's once the implant, the surgical site's fully healed. We would see the patient for the switch on, normally follow them up a week later for fine-tuning, and then generally weekly appointments after that for a number of weeks. So there is quite a lot of input from the team over these early weeks, and that's quite a big commitment that we're asking from patients. But gradually over the first year, these appointments become more and more spaced out. We tend to follow people up at 3, 9 and 12 months. And then more recently have moved to a patient-led follow-up appointment after that. So we're really not seeing these patients routinely every year now. We tend to get them to contact us if there are problems with things. We do follow up in year 6 to upgrade the speech processor. And as I mentioned before, most patients find that the sound quality is very strange with the cochlear implant at first. We do recommend that patients try to use the implant device all of the time. There's a lot of emphasis on that. We do think that's the way that the patient is going to get the best benefit from the implant, is to just put it on in the morning, leave it on all day long, and take it off when you go to bed at night time. And then we know that the sound quality and the patient's ability to understand speech with this device will improve over time. So there's lots and lots of encouragement, lots of reassurance over the first few weeks and months using the implant device. If we just go on to the next slide, Simon, the rehabilitation, which is a kind of auditory training program. We talked about this already, that these patients need to practice listening with the implant device. So from the clinic, we provide guides to how patients can practice. There's lots of online resources now, so people can do the training at home on their computers and on their devices. Some of these speech processors connect directly to technologies, so people can listen to music and practice listening to audio books connected to the speech processor. So that's all good stuff that we do these days. And we guide people about use of other technologies that can help with their implant system. Where it's appropriate, we would practice listening on the telephone and understanding conversations and practicing strategies for better listening. So lots and lots of practice. This is really the hard work for the patients, is what they're doing at home and how much they get to use the implant device and how much practice they get. That does seem to improve how well people do with their implants and how much benefit they get from them.
Great, thank you very much. Just a couple of questions. We've had one from Laura saying, would you consider cochlear implantation in unilateral profound deafness in a paediatric patient? I don't know, Deborah, do you want to answer that one?
It can be considered. It can be considered in single-sided deafness. We have probably a handful of adult patients who have received a cochlear implant in a deafened ear. I think it's been very challenging for these patients to make sense of the signal together with the hearing they have in their normal hearing ear on the other side. So yes, it is a possibility to do that.
Yeah, I mean, the important thing to say as well is that actually in the UK they're not funded, and the ones that we've done have been part of research projects, but there are countries around the world that are allowed to do them. So there is some literature out there about outcomes, and it probably does give some benefit in terms of directional sound ability, but sound ability or hearing ability in noisy environments I think is quite limited, and it's been a bit disappointing, to be honest, that our experience of it, hasn't it? I think it's fair to say. I
mean, there are some issues. I mean, the question was about paediatric patients, and obviously that brings into issue about congenital deafness and processing and things. So if you were going to implant a congenitally deaf ear with normal hearing in the other side, it would really need to be done very young.
Yeah.
And also scan carefully, because unilateral absent nerves are actually quite a common cause for unilateral congenital deafness.
Yeah. Okay, fantastic. Is there anything else, Simon and Deborah, you wanted to say?
No.
Okay, brilliant. Well, I think that brings this part of the session to an end. So thank you very much